So, Dr. Scholes, we have had this new advent in imaging in prostate cancer, PSMA, this PET scan, where we're really able to see prostate cancer around the body if it is present. Now, I know that PSMA doesn't work in 10% of patients, and maybe they're not in this category, but what do you do for patients who, they've had surgery, their PSA is rising, they've had a PET scan, they've had a PSMA scan, and then they don't find anything, but the PSA is still rising. So what do we do in those situations?
That's a tough situation because historically we haven't had PSMA PET scans. We have had something called an Axumin PET scan, but that typically only lights up if the PSA is over 1.0, which by radiation salvage standards is kind of a high threshold. The radiation doctors want to treat people with a PSA less than 0.5. The PSMA PET scan is exciting because it can pick up cancers as low as 0.2, find where the cancer is, radiate the spot, rather than just doing an empiric blast away at where the prostate used to be or at the lymph nodes type of protocol, which we've been using now for a number of years. So it's not an easy issue, but it's good to talk about it because this is something that a lot of men with rising PSAs after surgery are going to have to confront. If the PSA's gone up to 0.2 or 0.3 or 0.4 and we're dealing with a relapse, we certainly do want to get a PSMA PET scan. If we find it, we want to treat the area of where the cancer is located. If we don't find it, do we wait and allow the PSA to go higher, hoping that scans down the line will start to show where it is? Or do we say, no, letting the cancer run is unduly dangerous, therefore we should just blindly shoot where the prostate used to be and maybe to the lymph nodes? There's no easy answer to this question, but I like to identify this as something where thoughtful people are differing and going different directions. There are factors that would influence your decision. The character of the cancer prior to surgery. Was it a really high Gleason score, a high PSA, a large tumor? Are we expecting a bad situation? And if we're sort of back on our heels and concerned about the cancer, then that might precipitate an attitude of we'd better just go after this and radiate the fossa, radiate where the lymph nodes used to be, give some hormones. And this would also be the case if the doubling time is very brisk. That's one mentality. The other mentality is that knowing where the cancer is such a valuable asset in designing the treatment protocol that allowing the PSA to go a little bit higher and following up with another PSMA PET scan, if you started at 0.2, repeat it when the PSA say 0.5. One could even argue that if the PSMA PET scan is going to be negative, should we do a different type of PET scan, such as the Axumin PET scan? Those tend to be more useful when the PSA gets up to around 1. Unfortunately, I'm unable to give a black and white answer of always do this or never do that. There's the age of the patient. There's whether the patient has fully recovered control of urinary function and sexual function. Radiation treatment to the prostate fossa can cause an exacerbation of incontinence. It can cause worsening sexual function. It's not as likely to be damaging as it is in a man who's initially getting treated with radiation, but it's still a risk. So all these things are going to need to be balanced out, and whether or not you decide to just go ahead with radiation or postpone it with the hopes that the scan will show something as the PSA gets higher is going to be a variable decision.
Hi, just a quick reminder, if you would like to join our cause and donate, we are a nonprofit and we want to get these videos out to millions of people all around the world. You can help us out at pcri.org/donate. Now back to my next question on a rising PSA after surgery. In waiting for the PSA to go to 1, you talk about the Axumin scan. The Axumin scan will pick up, cancer that maybe the 10% of patients who are not eligible for the PSMA PET scan would.
Yeah, it typically will. The other thing to consider too is that not everyone that gets radiated gets cured. So before we had these scans, experts who did studies said if you administered radiation to the prostate fossa before the PSA goes above 0.5, that you're going to have higher cure rates. The perceived side effects of the radiation by the radiation therapists are not that high. So there's a lot of enthusiasm for trying to get the radiation in before the PSA goes above 0.5. Of course, not everyone is cured by that methodology. The PSA may go down temporarily and start rising again, and you didn't get it all. And then these issues come in of doing further scans as the PSA goes higher versus putting someone on hormone treatment. We know with hormones we can slam the PSA down to 0, but there's a lot of good evidence through the intermittent hormone blockade studies that allowing the PSA to rise up to 2, 3, 4, or even 5 is not likely to have much of any impact in the long-term survival or the development of hormone resistance. So what do we do then if, yes, the PSA gets up to 1 and the PSMA PET scan is clearly not showing anything? Could it be that 10% subcategory of PSMA negative cancer? The answer certainly could be. Axumin PET scan is a logical next step, commercially available, covered by insurance around the United States. What if that doesn't show anything? That is certainly a possibility. Well, Dr. Eugene Kwan, who just spoke in our conference at the Mayo Clinic, has a proprietary type of PET scan called C11 choline PET scans, which also start functioning pretty well when the PSA gets above 1. So that's a completely different biology and methodology and gives another possibility of finding where this cancer is. Is all this effort worth it? Shouldn't we just put people on hormone therapy? I believe no. I believe the answer is that there's a huge advantage of knowing where the cancer is and allowing the radiation therapist to target that spot. People are still getting cured, even with metastatic disease, when you find where the cancer is. We even have something called FDG PET scans. Those will occasionally light up. Those are the traditional PET scans that are used for lymphomas, lung cancers, pancreas cancers, and in certain rare circumstances, those will also light up with prostate cancer.
So we've talked about, PSMA, we've talked about FDG, we've talked about colon, we've talked about Axumin, but where does MRI fall in the huge line of it? Is it all the way at the beginning that you do the MRI before the PSMA scan?
MRIs for relapses really are not that efficient. We used to do them just as we would do CAT scans and bone scans. But that was a different era, and you need a chunk of cancer that's about a ½ inch across before they're going to show up on these more traditional scans, which is nothing close to what these PET scans can accomplish. So I don't waste too much time with CAT scans, bone scans, and MRIs for trying to ferret out where relapse cancer is located. It can be used to try and confirm or refute. If you see a spot on a PET scan, it's not 100% sure that it's cancer. It's very likely to be cancer, but not 100%. And sometimes there's some ambiguity about a lesion, say on the hip or something, and an MRI to confirm or refute that it really is cancer can be quite useful. The CAT scans that are done at the time of PET scan are overread and compared, and they should show some sclerotic changes in the bone. These are useful confirmatory tests, but they're not very good for just going out and finding something you can't find.
As far as hormone therapy goes, do you have patients who have anxiety about their PSA getting that high and they just say, Dr. Scholes, I just want to go on hormone therapy, forget trying to find it, let's just go on a systemic therapy?
Certainly. Anxiety is an overlay of this whole field, and management of people's expectations and fears is usually best accomplished with just educating about the studies that have been done, helping people understand that they're not the first ones to go through this, and there's very convincing studies showing that allowing the PSA to rise to some degree is very unlikely to change the future because the hormone therapy is so efficacious. The whole goal being with hormone treatment is to get the PSA down to undetectable levels. Challenges with getting PSAs to undetectable start to become more prominent when the PSA is in maybe the 20 to 50 range. In almost all cases, we should be able to get people into a complete remission with hormone treatment, even if the PSA rises to some degree.
So from what you're describing, with the PSA and there kind of being this tension, this concept that, it really, PSMA will show up at 0.2, but then the radiation, doctors want to do radiation around 0.5, and then, sometimes it's not showing up, and then you have to wait till 0.9. That whole thing would be really frustrating for me as a patient sitting in that office, because I think I would get the PSA and go, oh my gosh, it's rising, but what if I have a treating physician who's kind of going, I don't think we need to do it yet? What would you do in those situations, and what would you tell patients?
Well, this is an area that we're still learning about. There'll probably be other new technologies coming along to help us make this decision of whether to just jump in and treat it. The problem is the treatment, though it's usually pretty well tolerated, it's not perfectly tolerated. Some men do have a degradation of their urinary control or their sexual function. It's quite tempting in many of the cases that I see to allow the PSA to go a little bit higher, knowing that that 0.5 threshold was set at a time when we didn't have scans, and we didn't know where the cancer was. There's such an advantage of knowing where the cancer is and allowing the radiation therapist to target the disease that I tend to liberalize a little bit and allow the PSAs to rise above 0.5 if necessary. It's wonderful if the scans show it up below 0.5, and I do get some blowback from the radiation therapists if we're postponing treatment over 0.5. But I think there is a rationale for allowing the PSA to go a little bit higher in some cases, as long as people are informed of the fact that this is still a little bit of a gray area.
As far as monitoring the PSA, the thing is, when you're talking about seeing it go from 0.2 to 0.5, how often should these patients be monitoring after surgery? Because I think that's an important point if somebody has had surgery and they're watching this video.
Right, so we routinely monitor people every 3 months when their PSAs are 0. But if the PSA is rising, and of course we're looking at the doubling time, because we know that fast doubling times are more consequential than slow doubling times, we may be checking the PSA every month. And so we want to define how quickly it's rising and make sure that we aren't caught by a surprise if something's rising quickly. It's not difficult to do. Simple test and run the numbers and see as you hit these different thresholds. Typically we would be repeating the scans. Perhaps at each doubling of the PSA would be a reasonable time to repeat the scans. And once you get up to 1, as we already mentioned, then we start thinking of some of the other scans for the 10% of men that are PSMA PET negative.
So today I talked to Dr. Scholes about a rising PSA after surgery. One of the main things that I was thinking about when I asked him to do this video is I had a patient email me. They said that they had a rising PSA after surgery and the PSMA showed nothing. And they were going, what do I do now? I don't know where the cancer is, but my PSA is obviously rising. There's no prostate there for it to be BPH or prostatitis, so what's the next step? So I think the best point that Dr. Scholes made in this whole video is that there are other options outside of PSMA. And I'll go ahead and share more information in the links in the description below this video. The fact that there are other options in imaging kind of relates to the fact that there's other options in prostate cancer in general. Unlike a lot of other cancers, prostate has a lot of options, especially in the last 10 years. Whether that's in treatment, imaging, side effect management, there's a lot of options. Now, the problem is that sometimes your doctor or your physician may not know about all the options. So what I would encourage you to do is print out the information on the other scans and discuss it with your doctor and say, do you know of a place I can get this scan if this scan isn't showing anything, because we do want to find the cancer. I would just encourage you, if you are somebody who has a rising PSA after surgery and you're watching this video and maybe you haven't even had a scan yet, write down the scan names and then also get your PSA numbers. I find a lot of times that patients don't know their PSA numbers themselves and know what would be a critical point of action. And those are very important to know. If you've just had surgery and maybe you're watching this video ahead of time, you should be getting, after surgery, you should be getting your PSA checked every 3 months for the first 2 years. And then after 2 years, you get it checked every 6 months. And then after another 2 years, you can get it checked once a year. So that's just a good point of reference to know how often to get your PSA checked. I would definitely take to heart what Dr. Scholes said, that if you see your PSA rising, you can go as often as once a month, and at least you can incrementally keep track of that. I personally would keep track of that as a patient. I would not be relying on my medical team to track my PSA and decide the point of action of when I'm willing to take treatment and go into that situation. It's good to know your options. It's good to know your PSA. It's good to know about the other scans. And then you can start to really build out the treatment plan or treatment plans of what you would like to see happen, and you can start to learn more about the studies and learn more about the outcomes of the treatment that you would choose. And then you can also build your side effect mitigation plan based off the treatment. This sounds like a lot of planning. I know it's very arduous, but if you need help, you can do so and find help at pcri.org/helpline. We have prostate cancer patients who have been through these situations, and they're very good at helping you build those plans out, and they can give you information that will help you have better outcomes with your medical team. So go ahead and reach out to them if you would like help with your personal case. If you have any topics you would like me to discuss with Dr. Scholes, you can go ahead and leave them in the comment section below the video. Thank you so much to the people who have left the comments. It has helped us build up our content and what you would find helpful. And it's very, very important to us that we hear your voice in that, because this is all for you. It doesn't really matter what we think as much as what you think. You're the ones in those office and what you're dealing with, and that's very important. And also give this video a thumbs up if you thought it was helpful. Don't forget to subscribe. But most of all, please remember, you're not alone.